This presentation is on cardiac murmurs. This is Esther Braza for Behrman University for NUR 674. Normally, with each contraction and relaxation of the heart, the flow of blood is moved through the heart chambers and valves. Beginning with the right atrium, blood passes through the tricuspid valve into the ventricle, out through the pulmonary valve, through the pulmonary artery, into the lungs, into the pulmonary veins, returning to the left atrium, through the mitral valve, the left ventricle, and then the aortic valve, returning oxygenated blood to the arteries and organs of the body. When all this runs as normal, the blood flow is inaudible. The only heart sounds you should hear are from the closing of the mitral and tricuspid valves, which is S1, and then the closure of the aortic and pulmonary valves, which is S2. Murmurs defined mean basically a turbulent flow within the heart or disruption of the normal blood flow through the heart. In a classic article on auscultation of the heart, Leotham noted that all murmurs are related to one of three factors: high rates of flow through a normal or abnormal valve, a forward flow through a constricted or irregular valve into a dilated vessel, or backward flow through a regurgent valve, septal defect, or patent ductus arteriosus. Murmurs can be described by location, intensity, pitch, radiation, and timing. The location is where it is on the chest of the patient, where you hear it the loudest. Radiation assesses the area over which the murmur is audible, like over the axilla or the suprasternal notch or the inferior aspect of the left scapula. Intensity, or how loud a murmur is not always equal to the severity of a murmur, so that's important to remember. Or rather, it is related to the speed of the blood flow. There are 6 grades in which we grade the intensity. Grade 1 is the faintest murmur that can be heard. It's usually softer than S1 and S2. Grade 2 is a faint murmur but has the same intensity as S1 and S2. Grade 3 is louder than S1 and S2 without a palpable thrill. Grade 4 is loud and is associated with a palpable thrill. Grade 5 is very loud and with a thrill and can be heard just with the slightest touch of a stethoscope. Grade 6 is the loudest, and you can actually hear it without a stethoscope. The pitch is the frequency of the murmur, in which it determines which may be high or low. The quality can be described as like scratchy or blowing, squeaky, or harsh, rumbly. Quality and pitch are closely related. Timing, to distinguish between systolic or diastolic murmurs, timing is very, very important, along with the heart sounds. There are different types of murmurs depending on the location and reason, either systolic or diastolic. With systolic murmurs, there is an ejection type and a regurgitant type. Ejection types, which are grades 1 or 2, there's a period between S1 and the onset of the murmur. This is from the ventricular outflow obstruction of some sort of either rheumatic or calcified AS, idiopathic hypertrophic subaortic stenosis, or pneumonic stenosis. Most murmurs are of this type. With regurgitated type, there is a murmur which comes from the flow as a result of the flow of a high pressure chamber to a low pressure chamber due to incompetent valves. Diastolic murmurs are associated with aortic or pulmonic valve regurgitation, an exaggerated flow state, or obstructed mitral or tricuspid valve. Subjective signs and symptoms upon clinical presentation will depend on the type of murmur. Increased age and or disease process, or depending if there is a presence of congenital defects, can present with varied symptoms. And of course, there may not be any signs or symptoms and may be discovered accidentally with physical examination with auscultation. So a complete assessment, a history and physical, is vitally important. Patients can have a variety of symptoms, chest pain, syncope, difficulty breathing, anxiety. They just may not know. They just may feel like something is just wrong, and they can't always quite describe it. Keeping in mind that depending on the type of disease process, there may be different presentations of each patient. The physical exam, along with the complete H&P, is really important to catch a lot of these murmurs that stem from valvular heart disease. This way, management of these patients can be implemented quickly. Like aortic stenosis has a delayed carotid upstroke, narrow pulse pressure. There could be a thrill at the second intercostal space. With mitral regurgitation, palpitation of the carotid pulse typically shows a rapidly rising pulse. The apical pulse is hyperkinetic and displaced downward and to the left. Auscultation of the patient with chronic MR can reveal soft S1, a loud P2, and an accentuated pulmonic component of S2 suggests the presence of pulmonary hypertension. An audible S3 is indicative of predominant regurgitation. The hallmark of murmur of MR is a pansystolic, which is blowing murmur best heard at the apex and radiating to the axilla or back. Set and standing maneuvers will result in a decreased murmur. Asking the patient to squeeze both fists in a hand grip will decrease or increase regurgitation and the intensity of the murmur. With aortic regurgitation, physical findings can depend on whether it's an acute or chronic find. Patients could be asymptomatic for decades with chronic AR, and then there could be a change in symptoms. Low diastolic pressure with normal systolic, resulting in widened pulse pressure, abrupt rise and fall in carotid upstroke. In acute AR, sudden symptoms of severe left-sided heart failure, like dyspnea at rest, orthopnea, paroxysmal nocturnal dyspnea, fatigue, exhaustion, and those things can be overshadowed by symptoms. Fatigue and exhaustion can be overshadowed by symptoms of pulmonary congestion in patients with acute AR. Most cases of mitral valve prolapse are diagnosed on routine physical examination. The degree of them mitral valve prolapse determines on whether there is an actual murmur that is heard. Auscultation of a mid-systolic click, which can be intermittent, an extra snapping heart sound of the lower left sternal border or at the apex. The systolic murmur is usually a late systolic crescendo type that can be loud and musical. The maneuvers that decrease left ventricle volume, such as standing, will both move the click earlier in systole and make the murmur longer. In our reading in our book, this table is really, very, very helpful in knowing the differences of the murmurs and their origins and the differences between the systolic and diastolic murmurs. It really just kind of lays it out really well, and I thought it would be important to include us here. The ACC and AHA recommendations include a thorough history and complete physical exam on all patients with suspected or known heart disease. The presence or absence of symptoms guides progression, staging, and treatment. ECGs, chest x-rays, transthoracic echocardiogram, two-dimensional imaging and Doppler studies provide necessary anatomic and hemodynamic measurements. The TTE is the standard diagnostic test for initial evaluation of patients with suspected or known valvular heart disease. They've also done the transesophageal echocardiogram, which those are a little more invasive, as you'll see in the next slide. Staging comes from the physical examination along with the TTE results. Monitoring by periodic TTE varies based on lesion severity level and valvular function. Changes in symptoms or physical exams also warrant a repeat TTE. You can see the two pictures here. One's a TTE and one's a TEE. And the TTE is less invasive because it's just an over-the-chest ultrasound. The TE is more invasive because it requires sedation, and they're actually going in through the esophagus and taking a look at the heart internally. As you can see, management can be very similar of all these different variable heart disease and murmurs. Depending on the disease, presentation, staging, and progression, there are different courses of management. It can be fine-tuned to each one. Patient reassurance, of course, is important. Cardiology should always be consulted and be on board, being that we are in primary care. Periodic monitoring is required, so knowing when the patients need to get back to cardiology, or have these periodic TTEs is important. Medication therapy for symptoms and to slow the progression of certain diseases is indicated, but for asymptomatic patients, there's not a lot of times they don't want to do any kind of medication therapy. Surgical interventions can be warranted and are successful depending on each different disease and the stage of the disease. So trying to remember all of these can be difficult. So there are many different mnemonics, and I thought I would put them in here for your memorization. They're kind of fun, and it helps to memorize them. So I got them from the websites that are listed, and you can read them there. And so that's my presentation. Thank you. And these are my references.